Good afternoon, everyone. My name is Jane McKay, and I have been asked to give an announcement to begin with. We are having trouble with Medio, and we're working closely with Medio to try to solve the communication problem. So hopefully by tomorrow that will be sorted out for everyone if everyone is wondering about messaging. So I'm here, and thanks so much for Dr. Arsenault for inviting me. I'm here to talk a little bit about long COVID. And although it's an update, I really have to begin this talk by saying how humbled I am by the plethora of knowledge and lack of understanding that it exists in the scientific community. So, what I'm really have decided to do is try to go through the leading mechanisms of action. First, the name confusion, the mechanisms of action, and hopefully, as this series unfolds, there's absolutely no way I can cover this in one talk. We'll get to therapeutic options that are coming. Okay, just a minute here. Oh, okay. So again, what I hope to do is review naming confusion and how it's complicated care delivery. I'm really going to discuss hypotheses of long COVID. I'm going to really focus on viral persistence, a little bit about viral expression and gut dysbiosis in the etiology of long COVID. Those words will become a little bit more clear as we go forward. So the naming controversy. Long COVID initially was the name that patients brought forward, long haul or long COVID. And that was really to explain that their symptoms just did not go away. And then came a number of other diagnoses, names, PASC, PAC, it goes on and on. And I think it's not meant with malicious intent. It's whenever anyone is presented with a new illness, particularly in the scientific community, they're really honestly just trying to make sense of a plethora of symptoms that really they don't have an answer to. So you'll find everyone pitches in, they create their own name. And again, it just creates more chaos because it becomes difficult for healthcare providers, patients, and family members to really understand what is going on. So again, post-acute sequelae of COVID, long haul COVID, the WHO definition, and on and on. And again, chaos. It's chaos. Unfortunately, even in PubMed, our tool that we use to research for articles, long COVID isn't recognized. So this confusion has not helped. And I bring it forward because what the confusion has really done is it's created an environment in the healthcare system where healthcare providers don't understand, they can't keep up, and they just don't know what to do. And I'm sure each and every one of you is experiencing this to some certain degree. So here, what actually Dr. Arsenault was the first to start, but we've gone toward using the Mayo Clinic long COVID definition. And I think what I have to admire the Mayo Clinic because they recognized very quickly, 2021, that there were phenotypes. In other words, the concept of central sensitization was existing and that phenotypes exist. So I'll talk a little bit about what phenotypes means before I get into this. But this is a group that's ahead of the game in understanding the illness. And that's why the name, why we use this definition. So Mayo really early recognized that long COVID has subclasses or different types of patients that have prolonged symptoms after COVID. And they describe the word phenotypes. And phenotypes are birds of a feather, for lack of a better word. individuals that have similar types that come together. And interestingly, I will bring to your attention that phenotypes exist in similar illnesses, such as ME/CFS. And there's many aspects that go on to influence a phenotype. So here we go. Phenotypes are the observable and measurable characteristics of a living thing. In other words, like attracts like, and groups with similar characteristics are together. And that's what the Mayo Clinic definition recognizes. So when we come to you and we talk to you, if you have long COVID, what we're going to say is there's three groups. I use the word three buckets. There's the one that causes tissue damage. This is the one that causes things like lung scarring, myocarditis. And we're not sure if the mechanism is the same between number one and number two, which is the not post-viral syndrome, central sensitization syndrome, which we're using as a term of long COVID. And then there's the other component of psychiatric and psychological that happens in part because of the neural invasion that happens with the SARS-CoV virus and its downstream effects. So just to go back, we use this definition for a purpose. The reason we use it is it makes sense, and it really recognizes that there's groupings of the disease, and it's not one illness. So I want to talk about how medicine is finally catching up, and they're catching up 4 years later. I'm not trying to say that we as the scientific community isn't understanding, but what they're recognizing is this is a real problem, and maybe the way that we started wasn't the right way. So this is coming from the New England Journal of Medicine. And for those of you that don't know, the New England Journal of Medicine for someone like myself and Dr. Arsenault and many researchers and clinical physicians around the world is the gold standard journal. So when we have someone writing in this journal or having an article in this journal, we all pay attention. So this was a perspective that was written in June by a group, and I'll talk a little bit more about it. And what they were saying in this group, 4 years later, we can do a lot for acute infections. We can do a lot for vaccinations, but 10% or more with long COVID have suffered. So what does that mean? It means at least 65 million people around the world have long COVID. Now that's an underestimate. You may not notice this, but there's no longer things like COVID dashboards. There's no longer keeping of records of how many people have COVID. So, the number's going to increase. And I really feel this is a action call for our scientific community around the world to start getting busy. And I know this is a busy slide, but I would really like to go through it with you just because it's highlighting a lot of what is wrong. So the absence of evidence-based treatments has fueled frustration of patients and their clinicians. This has led to, and then also we have shaky, fragmented healthcare systems. And the pandemic did not help that. Physicians, nurses, many healthcare providers left the profession in droves. And the system, as best as it could, did its best, but wasn't able to provide the care that was needed in this complex and multifaceted disorder. Again, I've talked about the multiple definitions. It's not helped us at all. And then finally, there's two more. I think the pathophysiology, meaning the reason why the illness occurs, is elusive. it's because there's multiple things going on, multiple different organ systems, and really, I have to say, a lack of understanding of long COVID. And this, if you don't understand the basics, it's hard to make studies happen, and it's hard to influence care. And this is the one that really upsets me the most as a clinician and an advocate, is patients with long COVID are subject to stigmatization because of perceived simulation or psychosomatization of symptoms. Again, this is coming right out of the New England Journal of Medicine, and they're saying, hey, we've made a mistake. This shouldn't have happened. But that doesn't undo a lot of damage. So I just hope that all of you understand your suffering is real, and we understand that, as do many, many others. I can't apologize for things that I didn't do, but I do think the healthcare profession does need to recognize some faults. So the long COVID work that's being done now has been creation of hubs of research and clinical care. And I'd like to mention RECOVER. RECOVER stands for Researching COVID to Enhance Recovery, or RECOVER. There's multiple sites throughout the United States, not in Canada. At a later date, I'll talk to you about the Canadian initiatives. And really, this RECOVER has 4 aims: multidisciplinary care, partnered with research, evidence-based care, leveraging innovation, and really building a network of healthcare providers that understand and can treat long COVID patients. So it's interesting. I listened to a rounds from the UCSF, which is University of San Francisco, and they're very large medical educators. And I had a very major epidemiologist publicly say he's thankful that patients have come forward, because he feels without this groundswell of continuing lobbying, this wouldn't have gone forward. So it's just a recognition that we do have to work together at the grassroots level to try to drive change. So here we are. So what are some of the progress in 2023 is identification of risk factors for long COVID. It's more common in females. It's more common in older age. It's more common in severely affected patients. If you have diabetes, obesity, HIV, it's more common. Older variants, plus the impact of genetics and epigenetics, have an influence, and lower socioeconomic status, which is more from the United States. So SARS-CoV will lead to COVID. The vaccine and treatment, where there's been a lot of work, has helped, but it by no means has stopped this upper line. Okay, and this comes from a infectious disease specialist whose work actually started in HIV. He switched over to SARS-CoV-2 because of the similarities that he was seeing, and his name is Michael Pelosi. So here's hypotheses, and the hypotheses of long COVID. This is coming from Nature, which is a fairly important paper that we use as clinician scientists to guide our understanding. This is from March, and I just want to try to take you through the 5 that are listed here. Immune dysregulation. Now, that one is a lecture in itself, but really it's the immune system not working properly. What does it lead to? It leads to persistent viral infection, and it leads to expression of latent viruses like herpes virus and EBV. Gut dysbiosis, which I will be talking about. Autoimmunity and immune priming will be in our next lectures. Blood clotting and endothelial abnormalities, again, another lecture. And dysfunctional neurologic signaling. So 5 different theories for the root cause of long COVID, and they're simultaneously occurring. And the problem here lies in lumping everything together. In other words, every long COVID person having long COVID, regardless of how, if it's been someone with tissue damage or no tissue damage, they've all been lumped together. So in other words, the phenotyping hasn't gotten to this level. So I'm hoping that it will, but I wanted to put that caveat in there. So you have a bit of an understanding. There's more work to come. So again, viral persistence, I'm going to spend quite a bit of time on. Gut dysbiosis, I'm going to talk about today. Immune dysregulation is another lecture coming on later. Clotting changes in small vessels and platelet cell abnormalities, and nervous cell signaling changes. Now, this comes in many different forms. The 2 forms that I have used are Nature Medicine and the grand rounds done on long COVID in 2023, which are both available for you. I want to talk about post-viral syndrome and viral persistence, because it comes up a lot when I'm talking to individuals about long COVID. And I think that I have to go one by one through everything, because there's no one thing that we can grab onto and treat. So what I like to say is learning from the past can help inform the present. And now infectious disease specialists have for years known about post-viral illness and increasingly viral persistence. There's papers written 30, 40 years ago about this, but really they haven't known what to do about the data. And I wanted to just introduce to you someone named Edward Koch. I don't introduce him to you to understand viral syndrome, but he's the father of how we understand today how viruses cause illness or bacteria cause illness. His was particularly in tuberculosis. So I think the biggest message here is there is viral persistence, and we need to look from the past to understand today. So post-viral illness is not new. I've listed a few: SARS-2, Ebola, HIV, EBV, dengue fever. Many others cause long-lasting symptoms, and they end up with the name post-viral syndrome, Ebola syndrome. So trials are existing in each and every area of these problem sets, but we haven't found the answer there. And I think what it's highlighting is how complex this is. But SARS-CoV-2 is so prominent because of the magnitude of impact on you and the suffering. People with Ebola, HIV for sure, EBV, dengue, all have illness, but the impact of SARS-CoV-2 nationally, internationally, is what's driving the wide and large numbers that we're seeing. So I wanted to just, again, try to highlight SARS. There's all those names. SARS-CoV-2, by the way. Ebola has 2 names: dengue, polio, SARS-1, chikungunya, and on and on. So those are the names. These are the studies. So it's not like scientists aren't trying. They are trying, but they are stymied because it is so challenging and so difficult. And the quality of the studies that they're doing is limited. And that's probably because of lack of funding, quite frankly. All the studies that you see under type of study here are not what we call the gold standard type of study, but it's the best that they can do. So lots of big work is being done all over with post-viral syndrome. We don't have the answer yet. Again, more just for your reference. So what this illustrates to me, that virus infection can cause long-lasting syndromes. We have a lot of studies, but we have no clear way forward. And what it illustrates is how difficult it is in the scientific community to go from a syndrome diagnosis to scientific information, and finally back to the patient with meaningful ways of making a difference. I had one speaker that I listened to recently who said, SARS-CoV-2 is really where cancer and HIV were years ago. And I want to give you with a bit of hope. HIV, Dr. Arsenault have enough wisdom, as probably the best way to say it, to have lived through HIV as an acute illness and watched the suffering and the death. And now, to us, it's just another chronic illness. Not just, it's a chronic illness. We, in our lifetime, have seen that happen. SARS-CoV-2, I'm hoping it's a little quicker, but actually HIV since 1995 has been a chronic illness. So there's hope. I wanted to talk to you a little bit about acute COVID. This is the event rates of COVID using an antiviral. This is acute COVID, but it's also looking at post-COVID. Now, this is a study that was done from EMR data, so not the best quality, but what it's saying is, what this study is saying is that perhaps using antivirals may have an altering effect, it may alter the presentation of long COVID. This was one study. Now, for this study, there's two others that say something different, but I wanted to let you know that they're thinking about it. So what happens in acute COVID? We know that antiviral treatment decreases the risk of acute COVID, perhaps long COVID. And this study, for 5 days of treatment, we noticed a decrease in disease severity. Perhaps there may be a signal that it's altering long COVID. And definitely in this particular study that was done by an epidemiologist in San Francisco, there was less tissue damage, myocardial infarct. So, so I hear a lot about people. So that I'm indirectly referring to Paxlovid. And I then, when I talk about Paxlovid, a lot of people ask me about rebound from Paxlovid for acute COVID. And I've put in the slide deck there for you, the reference page to the Yale Medicine Clinic that is running a lot of trials regarding Paxlovid, and it talks about rebound in a lot more detail than I will be doing here. Essentially, it's return of symptoms after Paxlovid treatment for 5 days. The symptoms are mild. In the study done, it was 1.7% of studied patients, and the study's not clear why it happens yet. But rebound occurs. So the Paxlovid resistance can occur too, and that's something I wanted to bring forward. I don't get asked about it much, but I think it's really important to understand, because it plays into the other mechanism of therapy of interaction, which is the immune dysregulation. So Paxlovid resistance occurs primarily in those that are immunocompromised. For an antiviral to work, you have to have a relatively intact immune system to help clear SARS-CoV-2. So it stands to reason, if you don't have the immune system, then it's going to be hard to clear the agents. So maybe it's not actually resistant to resistance to Paxlovid, but rather the compromised immune system. So what about metformin? Now I bring this forward because Dr. Arsenault and I talk about Paxlovid, metformin. A while back, a study was put together that really said 3 days of testing positive with SARS-2 led to 40% fewer long COVID diagnoses following 10 months only compared to placebo. It's very controversial in the scientific community, and I find it really interesting because, it's a pretty innocuous drug, and this study, was a bit ago, and really the last lecture I listened to said, yes, go ahead, give metformin, but we need more information. So we're still sticking with it, but just a little bit about it. So I want to talk about what is viral persistence. Why does it happen? Why does the virus stay? So the virus stays for multiple different reasons: chronic inflammation, immune dysfunction, microthrombus, and you find that there's persistence viral infection in the mucosa of the gastrointestinal tract, causing symptoms. There may be cardiovascular persistence, causing the inappropriate sinus tachycardia, muscle pain, and low-grade fever, lung persistence, causing perhaps some dyspnea, and brain persistence, causing the ongoing olfactory changes that we hear, or the smell, when I say olfactory, of smell and taste. So the virus alone isn't there because the body can't get rid of it and it's too strong. The virus is there because the whole mechanism of how we deal with virus is unclear, is not working. So I want to talk about the Find COVID study. This is another study out of California as well. And what they're doing is they're giving individuals, it's more of an observational study. They're following for 3 weeks. And what they're looking at is actually viral shedding and viral load in relationship to whether or not they go on to have long COVID. And son of a gun, viral persistence is what they're seeing. So Find COVID, which is again coming out of California, is saying more virus long shedding predicts long COVID. Again, by Peluso, the fellow that I've been following. And viral persistence, there's viral evidence of pieces of virus persisting up to 2 weeks. Sometimes we can find spike protein measuring up to a year. And in samples, this is not as important, but in this cohort, samples prior to vaccination, there is viral persistence even with vaccination, and now without vaccination here, and with vaccination. Again, here we are 10 to 14 months later in this slide, there's still viral persistence. And again, I feel like I'm going on and on about viral persistence, which I am, because I'm trying to make a case for the multiple pieces that are ongoing right now that are leading us to have long COVID, because there are areas where research is going to happen and is happening. Again, viral persistence, any antigen and the spike protein, look at the month in the last column. You see antigens still present. And again, I'm saying much the same thing. The virus is persisting, and the impact isn't fully known because it's only one piece of the puzzle. I want to talk finally about the PAX-LC study. So Paxlovid for long COVID. This is an ongoing study right now in Yale. There's no preprint available at the moment. It's a 15-day trial of Paxlovid against another antiviral. they're enrolling long COVID individuals with no tissue damage, which is really exciting to me because it means that's the population we're seeing the most of. They're using what are called PROMs, or patient-reported outcome measures, and also they're looking at biomarkers. So everyone talks about, with excitement, I need a biomarker. What it means, biomarker is a test. If I have a test, I can do something with it. So that's why you hear the word biomarker being thrown around all the time. So results are to come. There is some thought that the trial may be extended to more than 15 days, but when they designed a study, they said 15. So we're really in the early stages of understanding viral persistence. We need more time. But to me, what this means to me, and my understanding of immunology, which honestly I've had to go back to medical school to understand, is to me, this is a sign of altered immunity. It's not just the virus being stuck, it's the immune system not clearing the virus. And so that's really important. And I want to emphasize that when I come back on my next series, I am going to try to talk a little bit about the interaction between our immune system intact, our immune system in COVID, and how we can modify the two and understand the two, and how that is influencing the presence of more virus and more expression of virus like EBV and HH6. So this is a review article that I think is quite helpful because it talks about the cycle, really, basically, is what I'm trying to say. So you have persistent SARS antigen replicating SARS, and it's going on and on. What does that do? It then goes on. I don't have a pointer, so I'll go like this. Viral, cytopathic effects, persistent inflammation, an activated immune response, an exhausted immune response. So, and latent virus reactivation that's not related to CoV-2. So really, it's like this vicious circle going round and around and around and around. And I'm focusing primarily on the virus today, but there's much more to it. So this is a bit of an insight into what's to come in future lectures. And here we go. Let's go on to gut dysbiosis and long COVID. So what happens is the SARS-CoV-2 virus will bind to an ACE2 receptor. It then goes into the cell of the gut bowel, releases pro-inflammatory cytokines, which are proteins. It recruits immune cells. And what happens in the end game is an altered gut microbiota, biome. So I'm going to try to explain this a little bit differently. So what does gut dysbiosis mean? So there's an alteration in the microbiome. There's an increase in different bacteria, primarily bacteria growing, and those different bacteria growing are suppressing our normal microbiome. And what they're causing is production of bacterial byproducts that alter, again, the immunity in the gut. So, and there is likely movement of bacteria through the changed gut wall. So the gut really is a reservoir of changes in immunity, and I wanted to highlight that part and the viral persistence in this talk. So I wanted to talk a little bit about one potential etiology for long COVID that was just published, and this comes from a Hong Kong trial. A Recover, remember that's the group that I mentioned. A lot of words, but basically it's a prebiotic supplement in a powder pack given to people with post-acute COVID syndrome in Hong Kong for a period of time. What did they see? Impacts the management through gut it improves symptoms is really the bottom line. This is a lot of words, but really it improves symptoms. So primarily brain fog and fatigue were the two symptoms it helped. The study was short. It's actually an old study. I mean, they recruited starting in 2021, but it still holds promise for us in altering the gut microbiome with both prebiotics and probiotics. And with that in mind, I'm going to talk about, well, what can we do to alter pre and probiotics in our world, in our gut world? So I've attached with this slide Canadian Digestive Health Foundation of Canada. If you go to that website, they will give you multiple ways to strengthen your microbiome. Very simply, dietary changes. There's specific vegetables to eat, avoid sugar, processed food, and use probiotics. They didn't indicate what probiotic to use, but really, I'm not an expert in probiotics, but I think most probiotics, depending on concentration of what you're getting, are reasonable. Avoid antibiotics. We do try very hard to not give antibiotics because it will alter the gut microbiome. There's no question about it. We want to try to eat dietary prebiotic food. And I had no idea that there was dietary prebiotic food. So for a list of them, you need to go to this website. We need to remember to try gut-friendly fermented food. Kimchi, kombucha, all those new waves, what seem like new wave things to me, stuff. I'm sorry if I'm putting my old hat on here, but it's foods that might help our gut microbiome. Avoid red meat. And then the other things that affect gut microbiome: sleep, stress reduction, and exercise if you can. I just want to put a little anecdote in here. I never heard of the word gut microbiome until probably, 5 years ago. So this has existed in our body. I never learned about this in medical school. I'm sure Dr. Arsenault never learned about it in medical school. So we're learning every day about something new and something exciting. And I'm hoping that we maybe can make some change happen in our gut microbiome while the scientists try to catch up. So here's some important things that this talk that I went to said recently. The scale of long COVID is huge. It's on par with other high priority areas of medical research of HIV and cancer. We need more clinical and research infrastructure. We have to understand pathogenesis to make progress. In other words, unless we understand the illness and how it's creating pathology, we can't do anything. We need more clinical trials that are valid and helpful, because the last thing we want to do is harm people. We need to maintain momentum to get answers for people with long COVID and other infectious associated conditions. The amount of money that's been poured into the American research community is amazing. And I can't say the same for Canada, but billions and billions and billions of dollars, researchers that are all in these hubs of recover, working as hard as possible to try to get an answers, I think it's going to be, to where we're at with this illness. So that's a lot faster than I thought it was going to be. When I timed it, it was really a lot longer. So I have a lot of time for questions. And believe me, I can answer questions. I'll try to answer questions. but I don't have to, you don't have to restrict them to the topic that I'm presenting. I'm trying to give you a groundwork, and then we'll be adding on layer by layer. I hope that's a helpful approach. If it isn't helpful, let me know, and I'll modify my next lecture. So with that in mind, I'm open for questions.
So you can look at the Q&A, Jane.
Okay, all righty. Okay. So yes, this is taped. I'm sorry, I hope you can hear. Thank you. So what does it mean when someone has an elevated temperature? Body temperature ever since COVID. Okay, over a year ago. So I can't explain that one. So what happens with nervous cell inflammation is there I'll just point to the areas because they're somewhat representative. There's the hypothalamic, meaning part of the brain, pituitary axis. So that's the axis that controls body thermal regulation. So that's altered in COVID. Primarily, the mechanism is neural inflammation. And so what that does is it creates thermal instability. So you can have this low-grade fever, and it's part of the dysregulation in the hypothalamic hypopituitary axis. Simply said, inflamed nervous cells altering temperature regulation. Hope that answers that question. Dropbox link for the slides will come. I can't answer that question. Captions, sorry, I missed that. I sometimes struggle.
Yes, Jane.
What's that?
The healthcare version doesn't that we have for Providence Health does not do captions. And Bruno will send the slides out tomorrow.
Okay. So I apologize. One of my biggest concerns when I put this talk together is that it would be a little bit too much. And I respect that perhaps what I'm saying may be need to be a little bit different, and I definitely will modify for the next time. So I'm on my 6th round of COVID, and I've been tested positive this time since December 21st. My GP says I'm not contagious, but I need to keep testing each week as there is a blood test she wants to do that I need to be negative to take. I'm not quite sure I understand the question, but what I can tell you is you can shed viral remnants for quite a long time. In fact, that's one of the reasons we stopped testing for COVID in the hospitalized setting, because we recognized that viral fragments existed, but they're non-infectious viral fragments. So I'm not 100% sure what your GP was looking for. You definitely are not contagious after the first 5 days. But you may have a positive test. Usually it's a PCR test, and it's viral remnants, so pieces of virus. And 3 questions. Are LC numbers decreasing? Well, this is a hard one for us to tell because we don't have anyone measuring. There's no data registry for long COVID, and we're no longer no longer recording acute COVID. So with clear estimate of 1 in 10, roughly, every time someone gets a COVID infection, they have a 1 in 10 chance of getting COVID, and COVID hasn't stopped. We still get people are still getting COVID. So definitely not decreasing. what are the percent of COVID sufferers? So this is a harder question to answer because the percentage of those that go on to long COVID is somewhat stratified. But what the literature most recently is saying is 10% or more. And finally, if you have fibromyalgia, what are my chances of getting in long COVID if I catch COVID? 1 in 10, I would say. Fibromyalgia doesn't alter your immune system. It alters your nervous system wiring and pain processing. So I don't think you're at more risk. But I'm just going to stop there for a second and talk about disease prevention, vaccination, masking, hand washing, physical distancing are still very important steps for everyone. Now, it's really interesting. When I went to a lecture, every speaker said they are doing all the precautions because they don't want to get long COVID. So if that gives you any insight into protection and vaccination, of course. Whoops. So interesting. I have a really helpful comment here that I really was hoping would come up. There was a news article pointing to data that exercise is detrimental for those with long COVID. If I experience post-exertional malaise, am I damaging my body? What is the newest advice reintroducing exercise? Well, so this is great. This is coming from Lucinda Bateman, who's a very, very well-known researcher in the field of MECFS. And really, basically, what she's done is reproduced the study called the CPET test, cardiopulmonary exercise test. So what she did is she had individuals with long COVID do the CPET test, which is a test to look for oxygen uptake in our tissue over a 1 and 2 day time. In addition, she looked at cellular abnormalities in the mitochondria and muscles. And sure enough, the same findings in MECFS as there is in long COVID, meaning the muscles don't work as well, the mitochondria aren't working, there's inflammatory cytokines, increased lactate, and decreased uptake of VO2 or oxygen uptake. So it's funny. It made the press. Well, it's not funny. I shouldn't say it's funny. It's we've been saying this for a long time, and I'm very thankful for Lucinda for actually reproducing this, because she's really just said 65 million have the same problem as they have in MECFS. Please pay attention. So what should you do about introducing exercise? And this is where we talk about the gambling, right? So that's in our core group. If you can't exercise, don't try to exercise. If you're feeling better and want to experiment, go slow. My adage always is go slow and don't overdo it. It doesn't mean you can't get a little bit better with long COVID. It doesn't mean that you can't reintroduce exercise, but please don't do it if you're struggling with post-exertional malaise with minimal activity. So I knew this question was going to come up. Is there any evidence for hyperbaric oxygen therapy for long COVID? Well, there's some evidence. And some people will do it. Now, a lot of it has to do with the hypothesis of hypoxia, and that the hypoxia and nitric oxide distress. So does it make a difference? Well, it doesn't harm. The studies aren't really strong. People are doing it. It is available, but the study strength isn't very strong. But it gets a lot of press. So hyperbaric oxygen therapy has been trialed. There's some evidence that there may be a bit of benefit, but not very strong. People are doing it. Slides will be available for sure. Is it possible to have symptoms for more than one phenotype? Of course there is. You can have multiple different, you may not fit in a phenotype. That's the problem with phenotypes, is the boxes, right? So not everybody's in one box. So rest assured, you can have different, and when you put phenotypes together, when you're making phenotypes in a disease pattern, you may have 6, 8, 10. So, and they have a combination of symptoms. So you can be in 2 groups or a combination of groups. Having had long COVID for 2 years, I was re-diagnosed with ME/CFS when the long COVID clinic closed. How do you think this may affect research treatment if I'm now being treated under a different umbrella and not directly linked to long COVID and anymore, rather than continued long COVID? Now, this is a really interesting question. So, viruses will trigger ME/CFS. SARS-CoV-2 is one virus. Because you have ME/CFS doesn't mean you don't have long COVID. So I want you to understand, I think of it as umbrella. Under that umbrella is ME/CFS. So you haven't had a name taken away from you. You've actually just had a name given to you. Now, that doesn't mean you only have that one diagnosis, ME/CFS. So I didn't put the slide set up there, but there is a high preponderance of ME/CFS happening in the long COVID patient population. This is well known in the scientific community as well. And I was going to, at one point, go through what we know from ME/CFS and how we might be able to take that over to the ME long COVID world. So you do not lose your long COVID diagnosis when you have ME/CFS. Why doesn't the provincial long COVID clinic address autoimmune disorder? COVID gave me MCAS and MCS, but there's no support there. You feel like you're being gaslit. So I hear what you're saying. I hear what you're saying about being gaslit, and it is an unfortunate problem. There's no question that long COVID causes MCAS. I haven't seen as much for MCS, but I definitely have for MCAS. It's there. It's in the research papers. So I honestly can't answer why it's not happening. Autoimmunity is really part of the long COVID story. And in that, I will talk more about that. I do apologize that you feel that you're being unheard. It's not nice to have that. And I'm sorry that that's happening. There are studies ongoing in different places about the autoimmune dysregulation that happens in COVID. That was going to be in my next talk, in part because there's a lot that I had to cover. So again, hope that answers that. I had been in long-term disability way before COVID. I got vaccinated for COVID. In March, I got tinnitus out of nowhere. After seeing 2 specialists, MRI, I had no cure, no answer. I lost 95% of hearing in my left ear. I have no explanation why this happened, except that maybe it was the virus. And it was going to be wow. autopsy. That's terrible. So tinnitus is a symptom that can occur in long COVID. I've read about it. Tinnitus is a really, really hard symptom to manage. There are ways that we can look at it. There are tinnitus clinics, but it is part of the long COVID spectrum. And I haven't seen that much hearing loss, but hearing loss can occur. What can we do to help drive change in terms of increasing awareness of long COVID and the importance of avoiding infections? So please, if anyone could just take a few minutes to write to your MLA, to say there's not enough work being done, to write to the Ministry of Health. Patient advocacy at the grassroots level makes significant change. I really, really strongly urge you to do that, because unless I'll let politicians react when things come to them, the more you give to them, the more change they will react. How do you avoid COVID infections? I think I've kind of gone over that. Vaccination, the social distancing, masking, washing your hands. I had a stroke 3 months after I got COVID. Is it long COVID? No, that's a really hard one for me to answer on a video chat like this. So you can get clots in COVID, post-COVID. I can't comment on your particular situation. It would require a little bit more information. Are people with ME/CFS higher risk of long COVID? Now, that's an interesting question. People that have ME/CFS will have a setback when they do get COVID. That's what I've typically seen. Are they at higher risk? Theoretically, it makes sense, but I haven't seen that written down anywhere. What I can tell you very clearly is if you have ME/CFS, you are going to have a setback if you have COVID. Sorry, thanks for this talk from Angela, someone I know. I heard a researcher say that people with obesity fared worse to H1N1 because they are less likely to access care or receive antivirals. That's really a very interesting question, Angela. There is the obesity is a risk factor for long COVID. I sure hope long obesity isn't an unconscious bias to treatment. I would really, that would be terrible if it was. And again, I think advocacy, depending on shape, size, really is very important. It can't, I really think that's important. I can't really comment on the H1N1 piece, Angela. I'd have to look into that. In general, viral infections predispose you to higher cardiovascular risk outcomes because of the inflammatory syndrome. Now, maybe because obesity in itself can have an inflammatory component, that may be why there's that link. But Angela, I'm just going out on a limb. I'm not 100% sure. How can I get involved in the long COVID study here in Vancouver? Yep. I didn't put it in the slide. Go to the post-COVID ICCN. There is a multiple, you go on the research tab, there's information there. There is one study. There's a few studies going on, and I think please volunteer or be a patient partner. Unfortunately, I was going to try to put some of the Canadian studies in. So you might be able to participate in some of the Canadian studies. And I was going to do that in the next talk, but you want to look up something called CANCOV, CANCOV, and Long COVID Network of Canada. Those are two organizations that you might have a little bit of help with. And then worst come to worst, go to CIHR website, because that has a list of all ongoing trials. The ones that I'm familiar with right now is a trial on LDN. So there's that trial, but there's others going on as well. Is long COVID the same as ME/CFS? I think long COVID ME/CFS is part of long COVID. I don't think ME/CFS and long COVID are the same. I think they're different. I hope that makes sense. Rebound. Interesting. So David Griffin says it's inflammatory process of the disease. The first phase is the viral replication. Multiple studies have shown rebound happens with or without Paxlovid. Well, that's really interesting. That I haven't heard that one before. I'd have to look up Daniel Griffin. He's not the one talking about rebound in the Yale studies, who's the center of all the studies for Paxlovid in the US. So I'd have to read about Daniel Griffin. It's hard to mount an immune response within a week, so I'm not going to argue, don't know anything about it. So Paxlovid, should you have it on hand? Well, we do have, no, you don't want to have it on hand because it's got a short half-life. Within 3 days of your test positivity, you can take it. If you get it, it's going to expire. It might be harder. I don't know if it'll be harder to get next time. That's my only point on that one. Wow. Vaccine-induced bilateral Achilles tendinopathy. Wow. It's terrible. That's terrible. I really honestly, prolotherapy would only be one thing. I'm not really a big tendon person, so a rheumatologist might be a best option. I'm very sorry that you had that. So, is a reactivation of EBV? Yes, absolutely. EBV is reactivated with SARS-CoV-2, as is H8/6. Okay, so that's a given, that's known. So if I have long COVID, does that mean we have viral persistence? Up into a year, there's evidence in the literature that says you can have spike protein or remnants of SARS-CoV-2. That's in the literature. So where you are in your disease, you could, yeah, definitely. I think anyone who's vaccinated should keep getting vaccinated. I have to say it, and we're really, really strong about it. If you get, it's just, every time you get another COVID infection, your risk of long COVID goes up. So the reason we suggest vaccination is we don't want you to get a higher risk of long COVID. And if you have long COVID already, I'd still get a vaccination. What I do usually, I recommend pre-medding. I pre-med with famotidine, almost like a triple therapy, to block the histamine response. So Claritin or another antihistamine at 40 milligrams, famotidine at 20 BID. Those are the two that I do 3 days before, 3 days after. And that's kind of my current cocktail that I've been using. That's just to block the histamine response. That's only one of the responses. If someone has shingles, repetitive, wow. Could they have viral persistence? Yeah, it's interesting. It's possible, yes. So if someone is on valcyclovir with ME/CFS, with COVID, could it? So I'm not quite sure I understand the question, but really, I'm not quite sure I understand the question. The first question is HSV shingles repetitive per month. I would think you need to see an ID specialist, honestly. That's kind of out of my realm. The valcyclovir question, I don't quite understand, so I'm sorry I can't answer that properly. Is altered gut microbiome like linked to SIBO? SIBO is something different. SIBO stands for small intestinal bacterial overgrowth symptom. So now, if you have SIBO from a naturopath and you have the breath test, then I'll leave that with the naturopath. Is the SIBO from COVID? I can't really say that. I haven't seen that in the literature. All I've seen is gut microbiome. And when they're referring to gut microbiome, they're referring to large colon. So that's all I can say about SIBO and COVID. Lots of questions on SIBO, right? So I'll try to do a bit more research. I mean, honestly, with the gut dysbiosis work that I read, which was a lot, didn't talk about SIBO. It just talked about gut microbiome in the colon.
So Jane,
yeah,
Dr. Musavi will be doing a presentation on GI issues, and Gaetano just did a presentation on GI issues. I wouldn't put too much time in looking on SIBO.
Okay, thank you. They may know more than I do. What do you think about the use of macrophages to alter the gut microbiome? Well, that's interesting. It's an interesting question, and what I'm going to comment on is the macrophage is only one piece of the immune system. So I'm not sure, and I haven't seen it. Maybe I didn't read enough. Macrophages being used to alter the gut microbiome. So I can't really say yes nor no. Viral persistence, if there's replication, is there opportunity for transmission? Now, what they're saying is no. The transmission, it's actually in the tissue, from what I'm told. Now, you shouldn't be infectious, from what I understand. The Red Cross not all allowing blood transfusions for long COVID. My goodness. I'd have to look into that one.
The Red Cross doesn't allow transfusions from ME/CFS patients.
Okay, so more to it than that. Okay, I know someone who's a blood transfusion doctor. I'm going to talk to them. That one's really makes me very curious. Long haul study. So is this? I read the Hong Kong study. It's a brand in the U.S. I'm not 100% sure if you have to replicate the study with the brand, but if you have found it and you find it's working, continue. In yesterday's talk, we heard the most probiotics don't help. Oh my goodness. Contradictory evidence. I can't really comment on that one. Because I didn't give that talk. All I know is what the literature is showing. So, yeah, I don't know, Rick, if you have anything to add or if we should just pass on that.
There was a comment made by Gaetano. He just says that he hasn't found much benefit in his practice. It wasn't based on literature review.
So that would be what we call anecdotal evidence. So this Hong Kong study isn't anecdotal. I'm not trying to discount Dr. Morello's lengthy, long experience. The Hong Kong product is available, and boy, is it expensive. So again, I don't know. I don't know what to say. Should you use only the Hong Kong product? Or others? Is it class of it's kind of the same concept. Is it a class effect or not? To me, it would be until proven otherwise, really, honestly, in the world of science, we have to say, use the product, test it. But what we often say is it's a class effect. You can use others. So we use that in hypertension. That's another area of my specialty all the time. So I don't know if that helps. Could you please elaborate on how multiple COVID infections can lead to lower immunity, which not exposes you more to future COVID infections, as well as other diseases? That one is going to take me a little. I don't think it's lower immunity. I think so this is a tough question to answer, and I really can't answer it properly. So I'm not going to even stab at it. But what I am going to say is, why is the government downplaying and minimizing the effect of COVID? Good question. I think they want to get back to business. I mean, I don't want to be a cynic, but please do what you can to avoid getting COVID or any virus or anything. They all cause problems. So do your mask, do your hands, do your social distancing, and get your vaccines. Have you heard about whether or not the results of the response clinical trial is out yet? Oh, you got no, I haven't seen that one. Rick may have seen it. I haven't seen response, but honestly, I can't keep up with all the trials, so it may be there and I just haven't seen it. I'd have to look. Do you have any sources on COVID and menstrual cycles? Yes, there is definitely an impact on menstrual cycles. There is on the METV channel some information by Carolyn Lee on hormones. So you may want to have a look at that. But yes, there is an impact on menstrual cycles, basically. Can you add the links to the chat? Oh, okay. I'm so sorry. I'm hoping the slides will be able to link them. Otherwise, I can link them and add them, I guess. Is there any way we can trial 15 days of Paxlovid only if the Canadian CanCove group takes that on as a site, and only advocacy is going to do that? There's no off-label ad hoc. We're never going to get it covered for Paxlovid, but I certainly understand why. Powder, we recommended the SIM powder you can get, as has been mentioned, on Amazon, if that will be of help for you. Got COVID on mitochondrial function. So really, it all, at the level of the mitochondria, you get the inability or uncoupling of the electron transfer system, and that is probably the basic answer I can give you. So oxygenation and production of usable energy is altered, and that's the roundabout best answer I can give you. What if my GP doesn't believe in long COVID? Well, I hope to do enough education this year that every GP in BC will understand long COVID. I've got lots of talks planned. So I'm hoping people will listen. You know, it's very disheartening, to say the least. And I'm sorry. When you talk about tissue damage, can you have elevated blood pressure? Well, so, possibly. Um, and it's possible if you've had, there's multiple mechanisms of how that could happen, but I wouldn't put it, I wouldn't disregard it. I'm thinking of COVID dysautonomia as a potential cause for changes in elevation and blood pressure. There is this condition called hyperadrenergic POTS, which is high blood pressure in response to testing for POTS. It's a topic all on its own, but you definitely can see pressure elevation with that. Vaccines. That's a hot topic. I can't really answer that one very well. I'm going to just have to leave it. For probiotics, again, is it a class effect versus the probiotic in the study? Again, as scientists, we're told to use the study product. It's very expensive. Maybe another probiotic could be tried, and it's a class effect. I'm not 100% sure. Is PEM a feature of long COVID? Yes. Sometimes it's 2 to 3 days later, but yes. What treatment options are on the horizon being trialed? There's a lot. And the two ways for you to find out is to go to the trials.gov. I'd have to actually look up the actual mnemonic, but it lists every trial that's happening. And it will list everything that's going on. In Canada, we have CIHR and the trial networks. I meant to put them in one of the talks. I haven't put them in this one, but trials.gov is a good place to start. If I already used metformin to manage prediabetes, how I might not have displayed symptoms of COVID and possible allow for long COVID. Hard to know. I can't answer that question easily. I
Jane,
really don't have.
I
Go
think
ahead.
that metformin doesn't prevent COVID, it prevents long COVID. So it wouldn't stop you from getting COVID. It would just mean that if you did get COVID and you're on the correct dose of metformin, you'd be less likely to get long COVID.
Thanks, Rick. Red meat helps me with my blood sugar. Again, this is when they make recommendations, everything has to be taken, in context of you. If, red meat is helping you with your blood sugar, maybe it's the sustained protein effect and not the actual meat itself. So that's a thought. Really a visit to a dietitian or looking at the Canadian digestive health site that I read might be helpful. Do you think that a lack of antibodies rules out viral persistence? So viral persistence to me is a tissue problem. Antibodies themselves may not necessarily counter viral persistence because it's viral particles. I don't know, Rhiannon, if I'm answering your question appropriately, because most everyone with COVID will have antibody production. It's in the elderly, it's 4 months. In longer, it's 6 months. So, and they wane. So what we're seeing, what the studies are seeing in individuals is that there is viral particles existing, but that doesn't necessarily mean those viral particles are in the humoral immune system. So it's a complicated question to answer, but the bottom line is, I don't think it's a lack of antibodies. I think it's actually complexity between the virus and the immune system. So, will having ME/CFS before COVID help? I think it's going to make a big difference because, one of my lectures, I was going to do the parallel between the two. There's a lot of similarity. And I think what they're learning, if they do invest as much money in long COVID, they're going to find out quite a bit. And I do feel that might help ME/CFS. Um, in terms of fasting to reduce viral load, I really I don't recommend that. And I don't, maybe it may alter gut, but I'm not 100% sure that's going to make a difference. Just another question about vaccination. Yes, regardless, vaccination. Okay. So measuring lung damage in long COVID is a tricky one because the tests that we have, for instance, pulmonary function studies, CT scans, may not pick up the degree of damage. I'm not, there could be research-based studies that are available that might be helpful, but the garden variety studies that we have right now are not going to pick up. If you don't have ground glass opacification in your CT scan or MR, it's not likely that you're going to have a measurable method of lung changes. So Derek's asking about LC studies. Go on the PCICCN website, enroll or try to enroll. There's also, again, the CanCove study group, and then look at trials.gov to see if there's anything available that might be helpful. Again, I wish I would have got those that together, but I'm sorry I haven't. I think Omicron, the earlier strains seem to be more associated with long COVID. In the beginning, we used to say 30% of individuals having those variants would go to long COVID. So you can't really confirm. You really can't. I mean, it's just too hard, too difficult. Nicotine patches. Thanks. I was hoping someone would come up with that question. So this is a really interesting one. So one of the problems they feel is that there's an alteration of acetylcholine and the muscarinic, a type of receptor on the muscle. And that if you give nicotine, you're going to bump off whatever's in the way, and then you're going to actually make that receptor work. So there is tiny little study about nicotine and use for alteration of acetylcholine receptors. So that's what that's talking about. I was asked a couple weeks ago about that, and that's how I know that. So there you go. Autopsies on long COVID. That's a good question. I haven't studied in detail all autopsy, because autopsies are usually someone that's had major tissue damage. So I honestly haven't reviewed that. I can't say about the SIBO and fermented foods. I just think that when Dr. Musavi talks, it would be a good talk. She might be able to answer. How do we test to see where my immune system is? Well, that's a really interesting question. And there are multiple parts to an immune system. And there's no easy way to test for it. I know that's not the answer you're looking for, but there's no one test. Natural daylight on long COVID. That one I haven't looked at, but I know that there is light therapy involved in it. Whether it's natural light therapy or not, I don't know. So we usually say if you have had COVID, Paxlovid and metformin's a pretty good idea. So we're not shy on prescribing that for you. I've had post-viral syndrome since 2001 with H1N1. I take it that the characteristics and treatments are the same as those with long COVID. Yeah. Again, post-viral syndromes are not a new thing. We don't know what to do with them. Long COVID is significant enough that hopefully we might start getting some answers. Okay. Thank you. Do you want to cover the psychiatric sequelae post-COVID? I certainly can. Certainly, it's not, I definitely can cover that. Like, again, this series, I'm not sure how many series lectures I'm going to need to do, but if there's a need to cover the psychiatric neurologic piece, then that can be covered. I'm not, the only thing that's might be better covered by a psychiatrist. That's the only bit, and that we'd have to ask a psychiatrist to talk about that, because they know more about the pathophysiology of how that would happen. Does smell retraining with essential oils restore one's sense of smell? That one I don't know the answer to. I honestly don't know. Yes, we're sharing slides. I talked about hyperbaric oxygen. Are family doctors being educated about long COVID? Well, how many talks can we give? I think what my approach was to approach all 5 divisions of family medicine and offer to do a talk. I'm doing a talk for family practice in May, and then I hope to do a talk in November at the Family Practice Conference. And I know that Rick we've done Project Echo, which has been a wide education process for family doctors. So, I do kind of feel sorry for family docs. Don't take it wrong, but their job is hard. And I think sometimes hard because they have so much to keep their hands on and heads on. We do try to educate. Honestly, we do try. Creatine monohydrate help with long COVID. So I think that's really getting at mitochondrial dysfunction. So that's my understanding of creatine supplementation. I'm not a naturopath, but when I've read about it, that's what I've found. So it's being used. Could long COVID cause myasthenia gravis, like muscle weakness? I have to look that one up. It does cause muscle weakness, and it is at the level of the acetylcholine receptor. But it's not classic MG. I mean, there's probably case reports of it, but I'd have to. It's not a slam dunk, right? I've seen lots of different things, but I haven't seen that one yet. You've tested for spike proteins. You have a number. So here we have some information. So this is the problem. No one knows what to do with the information. So yes, you can have these elevations, but again, in the context of only one thing, we may not know what to do with it. Because it's little proteins, it doesn't mean that giving you therapy, there is no therapy for it. So is it a possible biomarker down the line? I think it will be helpful, but I don't think they have a good understanding of significance yet.
I think you're out of time, Jane.
Well, I did my best. I got to as many questions as I could. So thank you so much. I hope this was helpful, and look forward to another series with more thoughts and ideas coming in a near future date. Thank you again, everyone.